Hello everyone. So today we continue with our interesting topic is the gastroenterology. So when you see someone comes in with nausea, fatigue, and then the patient has several needle tracks are seen in both forearms. Okay, this is what they tell you: needle tracks, fatigue. So you do regular labs, right? You do regular labs. You see very high LFTs, like in the thousands. So you see the LAST like 4,000. They're both in 4,000s. What could be causing that? What is your diagnosis? Why is that? This is likely medications toxicity. Medications are the only thing that could cause this liver enzymes to go that high. This is a very high number of liver enzymes, and that's what causes liver toxicity, hepatotoxicity. Now you could ask me, okay, what medications that causes that level of hepatotoxicity? The very number one cause is Tylenol toxicity. If you take a lot of doses of Tylenol, could cause that level of hepatotoxicity. How can you save someone's life that have Tylenol overdose? You save them by giving them N-acetylcysteine is the antidote of choice. Okay. Now there is this patient came in, like 33-year-old man, comes in just for follow-up visit. He has medical history of achalasia. Okay. So how do you treat achalasia? You do pneumatic dilation, stenosis in the esophagus. So you basically dilate it. Kind of makes sense. Okay, pneumatic dilation. So over the next 10 years, what is the complications of this? What could complications of achalasia? Complications could cause squamous cell carcinoma. Why? Because the acid goes up to the esophagus, and that enough stress to the columnar epithelial cells and the esophagus could make it really pissed and could transform into something ugly, which is cancer. So now you could ask me, okay, what other things that could cause GI or esophageal malignancy? Other than achalasia, there is atrophic gastritis, prior gastrectomy, and GERD, increased risk for esophageal cancer. So now you could ask me, how about gastric cancer? What could cause that? What could cause that is atrophic gastritis or Helicobacter pylori infection, H. pylori infection. If someone have gastric surgery, like for bypass surgery or so, if they have gastric ulcers or pernicious anemia, like autoimmune affecting the stomach, this could cause gastric cancer. How about colon cancer? What can cause that? Obviously, any stress and inflammation in the colon can cause it. Colon cancer, like ulcerative colitis or Crohn's disease, could increase risk for colon cancer. Okay. All right. So now you see another case. Another case. You see 66-year-old man comes in with watery diarrhea. Okay. So you see watery diarrhea for the past 2 days. Okay. So you do test stool sample for C. diff and it's negative. Okay. And the patient recently took antibiotic, amoxiclav. Okay. So after taking amoxicillin augmentin, amoxicillin causes watery diarrhea and C. diff was negative. So what do you think you need to do here? So okay, diarrhea can be caused by many things. The main thing, if somebody comes into you with diarrhea, the things that you look for, does the patient, you first supportive measures and discontinue antibiotics, just give them fluid. And you look, do they have any fever or hypovolemia? Are they immunocompromised? Is it more than 6 stools in 24 hours? Is the symptoms been going on for more than 1 week? This is abnormal. Are there any peritoneal signs? Is there any bloody diarrhea? If the patient have any of those, then what you would do, you do stool studies like fecal leukocyte, ova and parasites, stool culture, C. difficile assay if recently done antibiotic. Okay. And then after you do that, if there is inflammatory diarrhea, then you do empiric antibiotic until the pathogen is identified. So you do Levaquin and Flagyl, usually that's what you get. If there is non-inflammatory diarrhea, you just do supportive measures, honestly. And if they just fluid, symptom control, okay? Treat their diarrhea. And if the patient doesn't have fever or no long symptoms, not more than 6 times a day, then this is just supportive measure, likely it's gonna go away on its own. So this patient, what we're gonna do, because they don't have fever or long symptoms, you just stop antibiotic and observe. Okay. Now, if you see a patient who's 55, comes in, he has acute pancreatitis, 4 weeks ago, developed acute pancreatitis, right? So now the patient comes in with abdominal fullness with the history of acute pancreatitis. What would you do for this patient? So you check lipase, right? Lipase is elevated as well, 1100. So what is your diagnosis? Lipase is elevated and history of chronic pancreatitis. Now he has abdominal fullness. What would you do? This is likely pancreatic pseudocyst. Okay? Pancreatic pseudocyst can cause abdominal fullness. It's one of the complications of pancreatitis. Alright, now do you see a patient who's 38-year-old man comes in with a severe alcoholic pancreatitis, okay? Drink alcohol causes pancreatitis, okay? So like any reasonable doctor would do, you do CT scan of the abdomen. You see something very serious, which is 40% pancreatic necrosis and fluid collection, okay? So this is very serious. Now this is not just pancreatitis, this is necrotizing pancreatitis, which means the pancreatic tissue are dying. When the cell dies inside the stomach, that's not good news at all, okay? And you see fluid collection. So what would you do? It's like aggressive measures require aggressive diseases require aggressive measures. So what you want to do, you can't just do supportive therapy, fluid, and that's it. No, you need pericutaneous CT guided aspiration. Alright, so now when you see infected necrotizing pancreatitis is suspected, so what would you do? You give empiric antibiotics, carbapenem or fluoroquinolone plus metronidazole, okay? And then you also do CT guided fine needle aspiration. When you aspirate, if there is a sterile necrosis, like there's no bacteria growing, just supportive care. If there is infected necrosis, that's very serious. You culture the bacteria and you target antibiotics based on the bacteria that is growing, and consider surgical debridement if no improvement by the surgeon. So consult surgery as well. Alright, now anytime you see 44-year-old woman comes in with abdominal pain, and then you do CT shows pancreatic calcification and dilated common bile duct, like 12 millimeter. Anytime you see dilated common bile duct, this is what would be ERCP would be really good answer for this patient. Okay, this is dilated. This is because this is pancreatic gallstone pancreatitis. So this can have three different types. Mild, just do supportive therapy. Moderate, without CBD obstruction, you do supportive therapy, and consider endoscopic ultrasound, MRCP, ERCP, if no improvement within 72 hours. Okay, what if it's severe pancreatitis with common bile duct obstruction or cholangitis? Then you want to do ERCP within 24 hours of admission. Okay, so that's what you want to do. All right. Alright, so now we continue with our discussion. So let's say now number 7, we see somebody with confusion and fever, confusion, bronchi, pneumonia, right? And then you end up being intubated. So what do you tell the family? You tell them PEG tube does not prolong mortality, to prolong the lifespan. It's only make things worse. Here you see somebody 39 came in with constipation and hemorrhoid, painful anal fissure, you know, how do you treat hemorrhoid? You treat nitroglycerin. Somebody here with painful midline anal fissure and large skin tag, this may be Crohn's disease, you do colonoscopy. Here, what we're talking about, somebody come in with abdominal distension, crackles, and then you do ascites, you see albumin 3.3, okay? So albumin 3.3, what could be causing that? This most likely heart failure, okay? So now we talked about anal fissure, in this case, management. How do you manage anal fissure? Usually, and what causes that? How to prevent it, okay? There are two types of anal fissure, primary and secondary. Primary is local trauma, if you pass hard stool, prolonged diarrhea, vaginal delivery, and anal sex. Secondary, if there's a previous anal surgical procedures, inflammatory bowel disease like Crohn's disease, TB, sarcoidosis, squamous cell anal cancer, leukemia, or there's communicable disease like HIV infection, syphilis, chlamydia. How does it present? Present with tearing pain after a bowel movement. You can have bright red blood on toilet paper or stool softener. You have perianal pruritus or skin irritation. And the anal fissure usually appear as a laceration in the posterior anal midline. And the chronic fissure can lead to raised edges exposing white internal anal sphincter fibers. How do you prevent it? You prevent it with the proper anal hygiene to keep area dry by wiping with moist cloth, high fiber diet, adequate fluid intake to prevent constipation, avoid anal trauma, avoid straining during defecation. This is how you prevent anal fissure. Now for the ascites, what do you do with the ascites? You see the protein, ascitic protein. If it's more than 2.5, this one 3.3, okay, so more than 2.5, it's heart failure. If it's less than 2.5, this is either cirrhosis or nephrotic syndrome. And this case, you depend on the ascitic albumin gradient, okay? If it's more than 1.1, that's cirrhosis. If it's less than 1.1, that's nephrotic syndrome. That's as easy as this. This is due to diagnostic paracentesis. If there is leukocyte and neutrophil, more than 250 neutrophil, more than 500 leukocyte, and the ascites fluid, then you do specialized testing like culture, cytology, amylase, because this could be infectious peritonitis or pancreatitis or malignancy. Okay, and that concludes. We talked about ascites, our session. We talked about ascites, heart failure. We talked about colonoscopy for Crohn's disease, nitroglycerin for hemorrhoid, anal fissure. About ERCP for dilated bile duct, percutaneous guided aspiration for pancreatic necrosis, pancreatic pseudocyst. We talked about that. We talked about stopping the antibiotic and observing for diarrhea that doesn't seem inflammatory, no fever or recurrent, achalasia and consequent cell cancer, fatigue, needle tract, LFT in the 4000. This is medication toxicity. And that summarizes the first section of GI gastroenterology. Thank you for listening.